Hello and a very warm welcome to everyone. I am Debita, your moderator from Clirnet, and I am so excited to have all of you here with us today, joining from across the country. A huge thanks to our wonderful doctors whose invaluable support makes events like this possible. We are so grateful for your time and expertise, and we know your presence here will make today's session even more special. Before we dive into the main content, let me share a little about Clirnet. It's one of India's largest live digital continuing medical education platforms where doctors can create, share, and engage with some truly innovative medical content. It's a space designed for learning, connecting, and growing together as a community of medical professionals. It is my great privilege and honor to introduce our esteemed speaker for today's webinar, Dr. Amitav Banerjee. Dr. Banerjee is a distinguished public health expert and currently serves as Professor Emeritus in the Department of Community Medicine at the Dr. D.Y. Patil Medical College, Pune, India. Throughout his illustrious career, he has made significant contributions to community medicine, public health research, medical education, and healthcare policy. He has inspired countless students, healthcare professionals, and researchers through his dedication to advancing evidence based medicine and improving population health. Today, he will be sharing his valuable insights on the highly important and clinically relevant topic Ebola virus. Can it turn into a pandemic? So, here is the short description of today's topic. Ebola virus disease is a severe and often fatal viral infection caused by the Ebola virus, primarily affecting humans and non human primates. It spreads through direct contact with infected body fluids and is associated with high mortality rates, hemorrhagic manifestation, and rapid clinical deterioration. The possibility of Ebola evolving into a wider pandemic highlights the importance of early detection, strict infection control, vaccination strategies, international surveillance, and coordinated public health responses prevent large scale transmission. So I will just hand over the session to you, sir. You can start the session now.
Thank you, Divita, and it's always a pleasure to come on this Clirnet platform to share the current medical topic. So today the topic is Ebola. Everybody must be concerned whether it will be causing the next pandemic. So just to give a brief overview, this is been recognized. Ebola virus outbreaks have been occurring since 1974. First, the Zaire strain, and all these outbreaks have been uh, taking place in Africa, different parts of Africa, Congo, Sierra Leone, Liberia, and there have been around 45 outbreaks since then. And the most severe outbreak was in 2014-16. There were more than 28,000 cases and more than 1,100 deaths. And the mortality had been quite high in the earlier outbreaks, around 40%. And outside few sporadic cases, those who have given travel history, so it has not established itself outside Africa ever. So presently also there should be no concern that way. But we have to consider some of the socio-economic factors, something about the environment, something about the stability in the country, the governance, which contribute to these, and something about the traditional rituals. There are traditional rituals around handling of dead bodies, traditional rituals about the food habits and the poverty and the lack of health services, very poor health services where there is lot of gaps in infection control because lack of equipments, protective equipments, lack of disposable syringes. So if there's an outbreak such as this, which are transmitted by body fluids and poor handling, without protective universal precautions. The hospitals also becomes the hub of transmission. Another hub of transmission is the rituals around the funeral services. The Ebola person who succumbs, they have got a lot of high viral load because the fatality results from hemorrhagic outcome. So there's a lot of maybe bleeding. Sometimes there is intestinal diarrhea, vomiting, diarrhea, bleeding. So on the surface, there is high viral load. And the rituals are, there is intimate contact with the dead body, where there is kissing, hugging, washing, all those, all relatives uh, under, they pay the homage in that manner. So that is very deep seated in the culture, and it is sometimes there have been violence when the health authorities have tried to prevent the community from this hazardous. And then large number of people who attend the funeral, they also get infected, and then they go back to the different villages, different places, and they also may get the Ebola because of the intimate contact with this body, infected body fluids of the dead person, and they in their turn may also succumb, and again the cycle continues. So this, all these are very important in disease transmission, and that is why this, and other fact, the origins are mostly suspected to be fruit bats, and this is the bush meat. Eat, they they eat this bush meat, they eat the fruit bats, sometimes cooked, some maybe partially cooked, or they may be handling the carcasses. And because of extreme poverty, they may resort to hunting for these things, eating these things. So these two things, two or three things are the weak spots. Eating the, handling the carcass, eating the raw, partially cooked bush meat, then getting infected, the rituals around the funeral services, then the uh, hospitals are ill-equipped to handle. So these, if this, and poverty, and then of course there is lot of political disturbances. So all these all contribute, which is a rapid spread of the disease. And that's why the mortality rate is also high inside Africa. Those sporadic cases, the mortality rate is much lower. In Africa, in the past outbreaks, mortality has been 40%, 50%, whereas it is less than 10% in those who get are found, they have the illness outside Africa, some travelers in few cases only. But as I said, it doesn't transmit, it doesn't spread because very intimate, it spreads like hepatitis B or HIV. You don't have pandemics and acute care because very intimate body exchange of fluids are required. So that way, I'll share some slides to give the timeline and some overview, and I'll be just, so this is the topic for today, as you all know, whether it can turn into, and this would be the scope of the session. The case definition, what is the virus, the cases, the clinical symptoms, incubation period, the geographical distribution, person, place, and time, past outbreaks, and social determinants. I already gave you an overview. What is the current situation? What is the position update on vaccine developments? What aggravating factors and social determinants, they go hand in hand, and the pandemic potential. So this is the overview of what we are going. So this is the virus, Ebola virus. It is a family Filoviridae. Those who are interested in the details, I'm not going to much detail. Family Filoviridae, and genus is Ebola viruses. And then it has got different strains. Present pandemic is due to the Bundibugyo strain. It's not exactly a very new strain or a novel strain. Earlier was Zaire, Ebola viruses. Bundibugyo strains have caused outbreaks in the past. It has caused outbreak first in 2007 and 2008, 100 cases in Uganda. And that time case fatality it was 25%, this Bundibugyo. And this name Bundibugyo came from the place in Uganda where it was first identified. So then second outbreak due to this particular strain is in 2012. That occurred in Democratic Republic of Congo, the same place where we are having the present outbreak, there were 38 cases and the case fatality rate was 50%. You see, in Uganda, the case fatality, when it was totally novel, the case fatality was 25%. And in 2012 in Congo, it was 50% and had 38 cases. That shows that it depends. Congo may be less developed than Uganda, so they could not handle more cases because cases required a lot of supportive treatment, IV fluids, other thing, rehydration, blood transfusion, it's hemorrhagic, something maybe like dengue hemorrhagic fever. So, so it is not entirely new. It is there with us for more than a decade or more, a decade and a half. And so these are the clinical features. Incubation period is 2 to 21 days. And clinical features is there is high fever, headache, mild muscle pain, fatigue and weakness, severe headache, pain in joints, fatigue and weakness 1 to 3 days. Then when the disease progresses 4 to 7 days, there may be diarrhea, vomiting. So again, the person is transmitting by fecal-oral route, just like cholera. So that's why the proper sanitation, proper handling of body excreta and body fluids, severe vomiting and watery diarrhea. So dehydration can cause death also. So you require so many supportive treatment, and all these are available, the mortality can come down further. Abdominal pain and maculopapular rash may be there. Then late terminal stage, there is the hemorrhagic manifestations. They may be bleeding from gums, bleeding in joints, confusion, delirium, and the person may go into shock and multi-organ failure. And vascular leaks are there, the extra vascular compartments, the fluids, just like dengue hemorrhage fever, coagulation abnormalities. And you can understand a country like DRC where the health services are primitive, how they can handle such cases. So no wonder the mortality rate has been so high, and with better health. So the root cause would be improving the public health infrastructure like all developing countries, removing the poverty, educating the people, literacy, because most do not believe in viruses also. So they will not believe that it is transmitted by kissing the dead person. So this is the geography of the present outbreak. So Democratic Republic of Congo, Ituri is the place in dark brown. Ituri is the place where the epicenter, and the neighboring Uganda, Kampala, there have been 19 cases. Ituri, there are about more than 500 cases and 101 deaths so far. Initially, it was much higher estimates, more than 1,000 cases and 232 deaths. But now, after confirmation, it is 550 cases and 102 deaths. There may be more cases. And another problem is diagnostics, because I think couple of years back, there were a lot of cases and deaths where disease X in the same place, Congo. And ultimately, they found it was a common endemic malaria. So there may be many people which may be going undiagnosed. There is monkeypox also. That has also been declared as a public health emergency of international concern. So this is like we are focusing on one disease at a time. We may be having other deaths, like earlier estimates, as I said, was almost 1,000 cases of year. Now they say there are 500 cases. So there may be another 500, maybe other causes of fevers and deaths, which may be not getting counted. So in public health, you have to see all the diagnostic for all the causes of fevers and deaths. So this is one aspect which unnecessarily may cause panic. Everything is attributed to one disease at a time. And these are the time trends. Initially, it started 17th May, WHO declared it a public health emergency international concern when the cases started coming up. And up till, this is up till, I think, June 5. So cases are accumulating, but it is not as explosive as they say, though they predict it will be greater than the 2014-16. As now, it is not showing any that it will be anything different. So there have been more than 35 to 45 outbreaks, as I said, and several major and repeated spillover events, like some people move from one country to other, like Uganda. Sometimes some people may go to West or some USA or Europe or some. So, but it is not very common. It doesn't have a pandemic potential because the person becomes so sick, the person cannot travel. And when the person is very sick, the viral load is high in the body secretions, the fluids and surface due to diarrhea, vomiting and other things and bleed. So that person will not doing air travel and all that. And therefore the transmission comes down. So any disease which has got very severe symptoms and mortality, it is very unfortunate for the individual victim. But from a public health point of view, it doesn't have a good reproduction rate or a pandemic potential. Very mild disease which have got a lot of asymptomatic and all, which will carry and cause pandemic. So these are the Bundibugia outbreaks prior to current emergency. Bundibugia cause 2 are documented. That is, I have already mentioned 2007-8 Uganda, there were 100 cases and the case fatality was 25%, and Congo 2012 and 38 cases. So Bundibugia did not cause a forest fire in the past also. 100 cases and 38 cases. Now it is 500 cases because maybe the diagnostics may be better. So there is, I mean, it is a individual tragedy, but public health problem. And if we have good health services, we can save more lives also. And these are the 76, it was first identified. Then 2014, 2016 was the biggest and most devastating, they call it. They were West Africa, primarily Guinea, Liberia, and Sierra Leone. And the conditions are very bad in these places, Sierra Leone and all, very bad, very primitive. So basically, it is the poverty, primitive, eating flesh, uncooked, lack of awareness of handling the carcass, body fluids, and 28,000 cases and 11,000 deaths over a period of 2 years. I mean, it's a tragedy. But you see, daily in India, we lose 1,000 cases from tuberculosis. So in 11 days, we have 11,000 deaths from TB. So just to put it in context, in a public health context. So the panic sometimes is uh, uncalled for. If we remove the root causes, we may have less. Recent years, outbreaks have continued, and now the present outbreak. We will come to the present. So this is the present situation. Total confirmed cases 550, confirmed deaths 101. So this gives a case fatality rate of 18%, 18.36. So that means probably there is some advances there in health infrastructure also, and we expect to. Earlier outbreak, there's a 40%, 50%. In fact, this Bundibugyo in Congo in 2012 caused 50% deaths. So now it is 18%. Even 18% can come down, I think, if we have got better health services. Uganda is 10% only, almost half than the 19 cases and 2. The same outbreak, which is biggest, this is already we have mentioned about this. The 2000, it's about a decade ago. It was a Liberia, West Africa, then Sierra Leone. There are still more deprived areas. So there the fatality is 40%. So I feel the fatality is not only the function of the virus, it is the supportive services, the health services, the caring of the patient, supportive care. And of course, there are some monoclonal antibodies and other developments, antivirals. Some antivirals have been tried in the past, like remdesivir and all, which has not worked. And the 17th outbreak in Congo, it is the 17th, and dozens of over the last 50 years. This is about the Bundibugyo strain. And this was the map of the most severe outbreak. That was 2014 and 16, where there were 1,100 deaths. Sierra Leone, Liberia, Guinea. So this was the last one. And this is diagrammatically how the transmission cycle. So infectious animal on the left side is the fruit bats infectious animal or maybe other small animals. In fact, a person gets contaminated by handling those food bats, by handling the carcass, and then the uh, person gets sick. So the body fluids, objects get here, fingers. Then if you have diarrhea and other things, so it can also transmit by fecal-oral route. So, and the host is the new host on the right side. So you can have awareness like isolate the patient. The first is if you can isolate on the left side, that is sort of quarantine. Then, unfortunately, most of the hospitals in Congo are keeping the patients in general wards. There are no infectious disease hospitals with isolation facilities. So all these are contribute to the magnitude of the outbreak. Then universal precautions for objects, fomites, needles, syringes, bed sheets, and other things. So again, poverty and lack of hospital, fingers, overcrowding. So poor hygiene, sanitation, environmental factors can propagate the pandemic. So these are the again social determinants. Balancing burial rituals with public health demands during the past experience. They have been like the health workers are trying to keep the body inside covered, and there have been violence also when next family did not get the body because they do not believe, some of them, they are not aware how it is transmitted, that there is something called virus, and they have got a very strong belief that if they don't do the rituals like kissing and handling the body by the relatives, the spirit will come and cause harm. So all those, as we know, in tribal communities, these are the rituals which are. So hygiene, they did a survey also during that, after that outbreak. They found that qualitative study, humanitarian response during the Ebola outbreak in Liberia. So these are the findings that they have a very strong belief in this. So for that, we require to communicate with the religious leaders, with the funeral services, and educate the community on how to give the last respects with dignity to the body and how to change their perception. And as you know, it's very difficult to change these beliefs. It may have religious connotation, it may have these. And so these are the other factors, the anthropological factors, which cause these outbreaks continuously, besides the poverty and other things, besides the sanitation and all basic health services. And what are the vaccines may be second or third or fourth priority, but main priority would be the prevention of infection by handling of carcasses with meat, educating them, wild boosts not to take. Again, maybe poverty. So basic cause is the poverty. Experts evaluating Ebola treatments, including vaccine candidates. Oxford Serum Institute of India also is on the verge of bringing out a vaccine. And of course, the vaccine, there are two candidates. One is the mRNA technique, which was used in COVID-19, and the viral vector vaccine like AstraZeneca Covishield, which was used again in COVID-19. So as we know, both of them did not actually prevent transmission. So we don't know how much, and it is still undergoing trials, though they expect it will be ready with 3 to 4 months. By that time, perhaps things may settle down. And of course, if vaccines are required, the priority should be the healthcare workers, because those who are handling their under constraints of resources, they are the most vulnerable healthcare workers, besides the family who are exposed to the body fluids. So they would be the maybe requiring it first. So vaccines are two candidate vaccines are there. And treatment, there are also some clinical trials are going on monoclonal antibodies. And of course, remdesivir, again, all those things which failed in COVID are all again in the pipeline. Remdesivir did not work in COVID, we know. In fact, it was initially, I think, developed for Ebola only. So remdesivir and combination monoclonal antibodies show some promise. And there is a question mark over ivermectin and hydroxychloroquine, where there are some, it was discouraged during the COVID also, and there is no mention during the this Ebola virus, against Ebola virus also. But there are some groups of scientists, fairly respected scientists, who say that ivermectin should be tried because it has got antiviral activities, in vivo, in vitro one, and also hydroxychloroquine. So they are very cheap drugs. They have got a good safety margin, but it is not, as on today, it is not recommended by WHO or anyone, but it is just, I mentioned it because there are some groups of people who say. So this has just, by the way, I mean, even remdesivir had no action. So we might as well try ivermectin. That may be the logic. And this is the oral for post exposure prophylaxis. These are again antiviral drugs, obeldesivir, and they are candidates. And vaccine, of course, post exposure vaccine candidate, mRNA vaccine. Bundugia vaccine being developed by International AIDS Vaccine Initiative, mRNA vaccine. Single dose RV-SV Bundubugia vaccine. And other candidate, as I said, is the developed by Oxford in collaboration with Serum Institute of India, Pune. So which is the viral vector, DNA viral vector vaccine, and mRNA, the same platforms which were used and not very successful against COVID. But the root cause is the transmission dynamics, which is facilitated by the socioeconomic factors, poor hygiene, poor sanitation, poor health services. So now let us see what is the public health response. So US lot of $518 million preparedness. So that is what we should focus on more, on the overall development of the country. And these are knee-jerk reaction after the outbreak has started. So in the long run, we have to improve the health infrastructure, people awareness, and because wild animals, lot of viruses are there. It is Bundibugyo, it is Ebola, it is monkeypox. There may be other viruses which may be coming from time to time. So we have to educate. And border management, of course, temporarily closes borders because the Uganda cases were there. And international risk, even the WHO says and the European Center for Disease Prevention and WHO currently assess the global level is very low. So it will not cause a pandemic. So when WHO says not a pandemic, we should definitely, I mean, though, as I said, it is transmitted like AIDS, it's transmitted like hepatitis B, hepatitis C, body fluid. So it will not cause. Transmission requires direct contact with infected body fluids. International travel links from the dense rural epicenter remain highly limited. So people, very sick people would not travel. So it automatically limits the spread of the virus. And we should always practice safe sex. So many diseases are transmitted, safe injections, safe body fluids. Even monkeypox, which spread 2 years ago all over Europe, was among the people in a high risk behavior, like drug addicts or high risk, promiscuous, high risk gays and heterosexuals. They have this gay parade and all in Spain and other things. So all this, if that type of thing it goes there, then it may cause focal outbreaks outside Africa, like it happened 2 years back in monkeypox. Otherwise, for a normal person with fairly fairly conservative or normal person, I would say, who is not indulging in high risk sexual activities or drug, so the risk is very, very limited. Or unfortunately, for the natives who are deeply in tradition, like funeral services or poverty or lack of health facilities. Even if you go for an injection, there is no sterilized needle. So those are the people who will be vulnerable. I think these are the references. So these are some of the references. The first reference pertains to the Ebola virus in Africa, the historical aspects. First and second reference, past, present. The third reference is on the traditional and religious practices. which are usually neglected by doctors and yeah, those who are interested in more in medical technology and vaccines and therapeutics. But the root cause is in medical anthropology. So there is a good paper on that, the impact of traditional and religious practices on the spread of Ebola in West Africa. Then the third paper also relates to that, hygiene programming. They did the study there in this paper I found in this 2014 and 18, 70% of the household did not have soap. You see, soap and water is very essential for to check the transmission. So if you, this is poverty, lack of soap, lack of water can aggravate these outbreaks. So these are the basic things. Then WHO vaccines and treatment, this is the link for the vaccine update and Ebola disease risk. So that's all I think. I can take a few questions. I can stop sharing the screen. So I think that's all from my side. So if there are any questions, I can take them.
Thank you so much, sir. Thank you so much for your such informative